Dr. Michael Ryan is Executive Director of the WHO Health Emergency Programme. Dr. Michael Ryan has been at the forefront of managing acute risks for the global health for nearly 25 years. He was Assistant Director General of Emergency Preparedness and Response in the WHO's Health Emergencies Programme from 2017 to 2019. Dr. Ryan first joined the WHO in 1996, which with the newly established unit to respond to emerging and epidemic disease threats. He has worked in conflict-affected countries and led many responses to high-impact epidemics. He is a founding member of the Global Outbreak Alert and Response Network, which has aided the response to hundreds of disease outbreaks around the world. He serves as coordinator of the Epidemic Response 2000 to 2003 Operations Coordinator of the WHO's response to the SARS outbreak in 2003, and also the WHO's Director of Global Alert and Response 2005 to 2011. He was a senior advisor on polio eradication for the Global Polio Eradication Initiative from 2013 to 2027, and was deployed in many countries in the Middle East. He completed his medical training in the National University of Ireland in Galway and a master's in public health at the University College Dublin. His specialist training in communicable disease control at the Health Protection Agency in London and the European Programme for Interventional Epidemiology Training. So I'm going to go over there, and then I'm going to ask Dr. Ryan some questions about his fantastic and exciting career. So excuse me while I position myself. Dr. Ryan, thank you very much for joining us today.
Good morning, Prof. How are you?
I'm good, and yourself?
Good, yes, good. Enjoying a couple of days off in the west of Ireland, actually, at the moment. So I'm on the same time zone as you all there in London.
Well, thank you very much for joining us today. Can I ask you to start by perhaps providing an overview of the structure and function of the WHO Health Emergencies Programme and what your role as Executive Director within that consists of?
Sure, I don't want to bore you with organograms, but effectively we are the program within WHO that's tasked with both preparedness, readiness and response to all types of health emergencies. So we take an all hazard approach. We deal with humanitarian crises, natural disasters and outbreaks, epidemics and pandemics. We operate at the three levels of the organization. We have our headquarters is in Geneva. We have 6 regional offices, and we've got 152 country offices around the world. So we operate through the various levels of the organization, both in terms of acute event detection, verification, and mounting containment response. So, for example, at the moment, we have teams, huge teams in Ukraine and Pakistan, in Uganda. We have teams on the ground for monkeypox. We have over 30 outbreaks of cholera right now around the world. The original 7th pandemic of the 1960s and 70s never ended. So a huge diversity of responses, but we're also dealing with preparedness issues. We're currently entering into negotiations for a new pandemic treaty or a framework convention on pandemics and epidemics. We're working with the World Bank on financial intermediate funds for funding preparedness. So a lot of work across the whole spectrum of governance, financing, systems, tools, and most importantly, workforce, and building rapid response teams that go anywhere in the world to respond to various events.
Thank you. And a question off the back of that, how would something come to your attention that warranted your involvement?
A number of ways. The most formal way is and increasingly used by countries is formal reporting to WHO. Under the International Health Regulations of 2005, countries are obliged to report events to WHO that could possibly constitute a public health emergency of international concern. And there are a number of criteria the countries use. So a lot of that reporting comes directly from countries. But we also have connections with laboratories and laboratory networks all over the world. The Global Outbreak Alert and Response Network is a network of 250 institutions constantly on the lookout for epidemics. We have the Global Influenza Surveillance and Response System, which does surveillance for many respiratory viruses, not just influenza. We have 200 250 WHO collaborating centers around the world. But increasingly too, we use non-formal sources. We have a system called epidemic intelligence from open sources. So we use AI-driven scanning of the internet and news feeds from major agencies. So we're constantly using that system to scan all of the public airways, all of the web, looking for signals of epidemics, which we then turn into sort of actionable intelligence that we can use to proactively verify the existence of events for countries. So many different sources, pulling it all together on a day-to-day basis. We deal with 3,000 to 4,000 signals every day. Work that out over a month, and that they come from millions of pieces of information that are scanned. But usually 1 to 4 events per day are considered to be of interest, potential outbreaks with international repercussions. In other words, outbreaks that either need that have potential to spread internationally or require international assistance to bring them under control.
Okay, thanks. And what are some of the successes and challenges that the WHO have had supporting the response to such outbreaks?
I think, well, you've got your own network there of pathology, hematology, and others around the country and around the world. We rely hugely on our collaborating centers, on our institutional partners all around the world, national public health institutes, everywhere around the world. So I think our success isn't our success as a secretariat. Our success is our capacity to draw together global expertise almost instantaneously. During COVID, in the first weeks of COVID, I think on February 4th, we had 15 or 16,000 scientists online in various pillars, just discussing the disease, what it was, how it was infecting, how it could be diagnosed, what were the pathological markers of disease, and what were the possible therapeutic and vaccine options. That's the real power of WHO. It's not a building in Geneva. It is a collective globally that works together to try and find solutions to these rapidly developing events that occur. So that, in a sense, is our superpower. The challenges are constantly, and I'm sure you feel that yourself in your own services, we're constantly struggling for funding. 85% up to 90% of my program's funding comes from specified funding. In other words, it's not from core funding to the organization. So we're constantly singing for our supper, constantly busking on the street to find the cash to do the work we do. And that's a constant strain, trying to be strategic, looking 2 to 5 years in the future when your budget horizon is 10 to 16 weeks. It's quite tough. That's a real challenge. We struggle too sometimes for transparency from countries. Countries still, there's a growing sense that countries want to be more open and transparent, but there are still massive consequences for countries being so. We saw with South Africa when they very much shared their information on their developing situation with COVID variants, how they suffered with immediate sanctions on travel. So there are real issues around how do we protect countries who want to be transparent, how do we protect their economies when they're open from a public health perspective, but can actually be punished economically for that openness. And that's a real challenge day to day.
Okay, interesting. Thank you. And obviously, from what you've said, there's a whole range of services and support and healthcare provision that you are involved in and provide, but specifically around laboratory services. Mm-hmm. Can you give some examples when you think they've worked very well in crises, and have they ever helped to really change the course of managing an outbreak or a disease?
Oh yeah, I mean it's. I'm way out of my depth here now. I have a secret admiration for the people who work on the pathology side of this, because they, without the understanding, we tend to focus on the virus, we focus on the pathogen, and that's great. We need to understand the pathogen, and we need those diagnostics. And certainly, I've seen those diagnoses made in the middle of South Sudan, in the middle of a shooting war, with a microbiologist, pathologist from Fort Collins in the US making a diagnosis of borreliosis with Deemster stain on a microscope that was propped up on some cartons, all the way through to the most sophisticated collaborations around developing assays. If we look at COVID, we had the sequence on the 11th of January. I think we had laboratory assays by the 14th of January. We were working with Charité in Germany. We had contracts being developed with commercial companies by the 24th of January, and WHO was shipping validated diagnostics to countries in the South by February the 4th, to 58 countries in the South that had no access to diagnostics. I mean, that's incredible when you look back 20 years and look at the speed of innovation. But what's really changed is that the innovation can now be turned into production and distribution very, very quickly if we have the right arrangements in place. We have a very strong lab diagnostics team. We have a virus evolution working group that's been absolutely central to our understanding of the evolution of COVID. Every week, twice a week, virologists from all over the world get together and they study how this virus is evolving, and they pool all the information from around the world. It gives us a real steer of where this virus is going, both in terms of its genotype and its phenotypic behavior. And you know, from a pathology perspective, the genotype will tell us what the virus looks like and how it might behave. But how the virus actually behaves in the human body is about the interaction with organs. It's about immunologic response. And it's such a complex process. Without understanding the phenotypic impact of these variations, we really don't know what's important and what's not. Something can look very different in a genetic sequence, but may not be so different pathologically. But something can have a small, tiny change in the genetic sequence and can have a massive impact on the virulence of the virus within the human body. So we have a lot of work with that group. We have a very strong, big team working on biosafety, biosecurity, on the sort of that side of things, and a lot of work on training laboratorians around the world in networks. So on the lab side, a huge amount in terms of diagnostics, but increasingly a lot of interaction with pathologists and immunologists and others around understanding how these viruses interact with the human body. So much of the morbidity, so much of the negative outcome associated with these emerging pathogens is really because you have a novel pathogen circulating in the human body with all kinds of generalized immunologically mediated responses. And very often the pathology is mediated more by the immune response than necessarily by the virus itself, which is a hugely important issue if we want to think about therapeutic pathways for drugs that might be useful in future pandemics. Modulating the response rather than going after the virus may be a more generalized way of looking at therapeutics, at least in the first 3 months of the pandemic with the new virus.
Okay, thanks very much. And you've touched upon the role of laboratories and pathologists in outbreaks. How do you think pathologists can help in preparedness for response for future threats?
I think many ways. I mean, first of all, that ability to scale up services quickly. We all found in the first part of COVID an epidemic or a pandemic, but when an epidemic occurs in country X and Y, then countries A, B, C, all the way through to X can come to the assistance of that country. So in that sense, the scale and surge can be generated from outside or within a country as well. But in a pandemic, every country is affected. So unless countries can internally surge and scale services and move services to the point of care, like diagnostic services, that ability to be able to move to distributed services, to scale up services in the front line, to triage diagnostic services in a way that the central, more specialized services don't become overwhelmed with repetitive, mundane work. So it's really about structuring services so that they can adapt and be resilient in a pandemic situation. Because what a pandemic does, it's a bit like one of those treadmill stress tests for the system. One thing I've seen in a rapidly developing epidemic is all of the weaknesses, all of the rubber bands and all of the duct tape that you have on the system breaks in a crisis, because everything gets geared up to 110, 120, 200%. Staff shortages, equipment failure, lack of scalability in your equipment, the inability to move from bench-based diagnostics to high throughput diagnostics, all of that stuff becomes brutally exposed in a rapidly developing epidemic. So if you're not ready before the epidemic or the pandemic, it's unlikely you're going to adapt and scale up quickly enough. You will eventually, and we saw that in the pandemic. Countries struggled and then recovered, but that struggling period can lead to delays in diagnosis. That struggling period can lead to unnecessary morbidity or mortality. So I think that the way in which pathology services can improve, their ability to scale services is important. And then I think the second part is that part in vital primary research, looking at understanding how these pathogens are interacting with the human body and being able to have more consensus more quickly on what's going on. If we look at something like post-COVID or condition now, or you know, from that perspective, what is happening there? We have a multitude of symptomatology and signs in people with anything from lung to neurologic to cardiovascular symptoms. And there are literally millions of those people around the world, and they are going to remain a huge strain on the health service, massive psychological strain to those individuals and their families. Understanding what's happening there, separating all of the different potential pathological pathways and understanding that so we can come up with therapeutic solutions is the second big challenge of the pandemic. One is dealing with the pandemic itself, and the other is dealing with the consequences of the pandemic and learning how to treat people properly for that post-COVID condition. So I think your services are involved at all stages, but I think that the biggest challenge, I think, for everybody was getting to scale, getting services to the point where they could operate at 200% for a very long period of time without the deep stress that's been caused to everyone. I'm sure your members are absolutely exhausted after the last 2.5 years. Certainly we are. And those people working on benches all around, they were not seen. I mean, the heroes that were presented to the world were the frontline doctors and nurses, and they are heroes, and the people in the PPE working on the wards and interacting with families. But behind them were thousands of people on benches working 24 hours a day, doing diagnosis, doing blood chemistry, doing support to intensive care, managing all of that. And they've been rather invisible in this pandemic. And I think they deserve a shout out because they work just as hard and just in many cases quite dangerous conditions in order to be able to deliver the service they deliver.
And given the fact that lots of the work that our members and so forth do is in the background and not obvious to you know, as you've highlighted, what can we do to promote and support the recognition of the importance of this work in sort of outbreak preparedness and readiness?
Well, I think you know, getting into those networks nationally and globally, being seen and being represented, part of the reason that I'm breaking my holiday today, Prof, is to actually come and say from a WHO perspective, thank you, well done, we need you, and highlighting the role that your members have played, and members in pathologists and all around the world have played in this pandemic. So I think there's an element of that. There's also an element of, I suppose, educating political leaders and others that you know, that it's not just a yellow ribbon syndrome where everything happens in the intensive care unit. That's great. That's great for the 15 seconds on CNN or Sky News or the BBC. But behind that service, behind that capacity, that pointy end of the service, there is a huge support service that's providing massively important professional services that keep the whole system running, and to continue to make that investment case. Certainly from WHO's perspective, linking the clinical with the laboratory, that's become a huge issue for us, linking pathology to medicine and intervention. In that sense, I'm sure you're probably sick of hearing it, but I've heard it many times that pathology is the link between science and medicine. It's the link that in taking what we can understand from a scientific point of view and being able to characterize and describe that in a way that it can change the way in which we do medical interventions or medical prevention. So I do think it's something that needs to be spoken about more and highlighted more. And certainly, if we're talking about preparedness for the next pandemic, the ability to run and sustain scaled up pathologic services across the board, or across the range of different sub-services that are contained within the profession, is absolutely essential.
Thank you very much. And in terms of the research around COVID, the scientific research that led to us being able to respond and understand the disease, what do you think are the remaining gaps of our understanding around COVID, and how could we address those?
Well, I mentioned post-COVID condition or long COVID. That's very important. We still really. I mean, I'd be actually interested in what your members think. I'm an amateur here, I'm way out of my depth, but I look at this disease and I wonder whether it's is this a virus that's mainly affecting the lungs, or is it a virus that gets into the system via the respiratory pathway and generates a generalized vasculitis? Because we've seen so many cases of neurologic and syndrome and inflammation in neuropathological sort of effects. We've seen generalized vasculitis and cardiovascular inflammation, everything from vasculitis to all myocarditis and many other different syndromes. So really fundamentally understanding whether how much of this disease is virus mediated damage and how much of this disease is mediated by immune response, and whether or not, and we saw that with the introduction of steroids being the first real life-saving therapeutic that was introduced into the system during COVID. So fully understanding that, and that's the same across all of the emerging pathogens. It's incredible to me that all of these viruses are extremely different, and I've worked on everything from relapsing fever to CCHF. I've worked in outbreaks of Ebola, Marburg, the different forms of Ebola, and in COVID and in SARS-1. And what you see this very, very different, maybe routes of infection, but in the end, you see somewhat similar pathologic effects. And it would seem to me that there's a lot of convergence in terms of pathological pathways. Now, I know it's much more complicated when you get down to the level of the different cascades that are triggered. But in the sense, it would seem to me that understanding the immunologic pathology and the way in which viruses interact with the immune system seems to me to be something that really requires a lot more investment, especially if we're to develop broad spectrum drugs that would allow us to respond to the first few months of the next pandemic, because we don't know which virus is going to cause that. And it could take us 6 months to a year to develop specific antivirals in that situation. Is there more we could do to understand common pathways for how these viruses cause the damage they do in the human body? That's a big question I have. I wonder if anyone out there has some answers or ideas of how we could structure investment around that work in the coming years.
Okay, thank you. And one last question. What do you think are the biggest threats to mankind going forward? And perhaps it's COVID, perhaps it's other things in terms of emerging diseases.
I think we're
awake at night.
Well, at the moment, an awful lot. I think we're in we're in a time of greatest threat, but also of greatest hope, in the sense that we can either accept our fate in climate, in conflict, in social inequity, and in epidemics, and they're all driving each other. And what we have is a convergence of these different intertwined threats. Cholera is occurring because of conflict. It's occurring because of drought. It's occurring because people are being packed into peri-urban slums. It's occurring because people are being displaced and they're becoming refugees and they're going into camps. We're seeing monkeypox outbreaks happening in refugee camps now. And while it may be seen to the world as moving in a certain community, it's also deeply impacting other communities as well. So what we see is this really, really destructive convergence of these different risk factors, all driven by human behavior. The viruses are not we anthropomorphize viruses, and we talk about how the viruses are looking for ways to escape the immune system. They're not thinking this through. We're just providing increasing opportunities for viruses to do what they do in terms of our encroachments and our very poor management of the animal-human interface and the biosecurity of that interface. The opportunities we're providing for viruses to amplify, even in healthcare settings. SARS-1 was mainly a nosocomial outbreak with community extensions. We see with Ebola, we see with Marburg, how poor infection prevention and control in hospitals is actually very often the amplifying event that brings an emerging disease to the attention of the world. And we see these huge processes now of dissemination and the speed at which these diseases can disseminate. But all of that is intertwined with climate change. All of that is intertwined with the fact that, if we look at COVID, so many people died in COVID, not because of the virus, but because they had unmanaged hypertension, unmanaged diabetes, morbid obesity, no access to healthcare services for 20 or 30 years. In fact, a lot of the morbidity and mortality in COVID was baked into the system years in advance of that virus emerging. So we need to address the issues of social justice, health justice, climate justice, and we need to understand that we're at a moment of great risk. But we're also, on the other hand, we can accept that fate and leave it to the despots and the autocrats and the greed merchants of the world to continue to exploit our environment and exploit our social systems and exploit our economic and political systems to their own gain. Or we can actually look at what we do have. We have a massively collaborative scientific community. We have an increasing activation from youth about the world that they want. I think if we can show that in human ingenuity and human the desire to cooperate, we only survived on this planet as hunter-gatherers because we cooperated. That was the difference between us and elimination, annihilation. We need to find that cooperative spirit again. We need to understand that our ingenuity and our creativity is what's kept us alive on this planet for centuries, for thousands of years, for eons. And we need to recapture that. And we need to recapture that and use science as one of the thin end of a wedge that can get us ahead of all of these different risks. So from my perspective, I have great hope on the one hand that is the defining human instinct. And then I get depressed when I think about the greed and the exploitation that just seems to drive this planet at the moment.
Okay, thank you very, very much, Michael Ryan. That's the end of my questions. We have got questions, I think, from our audience, Joe, that I think are going to pop up on there, and I'm going to read them. Are commonly used lab tests such as FBC potentially able to alert us to a new pandemic?
Okay, I'm going to assume FBC means full blood count or something different.
That's correct. Yeah. So basically, the basic lab tests help us to identify new pandemics.
Not necessarily, but what I will say is that very often it's an astute clinician or someone in a lab that actually often notices something unusual. And sometimes that's because someone in the lab notices that they have a cluster of patients and they might be from across a hospital environment, across a group of hospitals. So it's not just knowing the full blood count or whatever. And I think one of the banes of the life of the pathologist is not getting the clinical metadata when you're asked to do tests. And I've seen many cases where it's basically a pathologist looking at a number of different tests and then looking at the metadata that's come with the test and saying, hang on a second, they're the same surname and they live on the same street. And very often it's that recognition of an unusual pattern of disease. And that may have some elements of the lab result, but it also has that need for that clinical context that goes with those results. And I'm sure it's something pathologists must rail around not having access very often to the data that goes with the actual test and the test result. So yes, it is possible, but it's that ability to train young pathologists to look for those patterns, especially across a range of tests or across a number of tests in a given period of time.
Okay, and paraphrasing what you've said, clinical information is of vital importance to be able to interpret findings and so forth and put it all together.
Yes, and you can put one and two together. Very often it's that little that ability to notice that in the clinical information there's something common across a number of different patients.
Okay, thank you very much. And you touched earlier on about the interaction between sort of animals and people. We cover veterinary pathology, and this is an area that is often highlighted for potential threats and so forth. Is there anything you can expand on about that interface?
It's hugely important. I mean, there's a lot of work going on looking at long-term study of the biome and looking at diseases that affect animals. I mean, we are in a sense, we've always captured the disease of the animals that we live with, tuberculosis or brucellosis or measles or any of these diseases, all potentially have had animal origins originally. And eventually those diseases settle down into a human pattern and they become our diseases. So our domestic animals have some risk to us, but very often it's wild animals that have those newer pathogens that we're not used to experiencing, and understanding which of those diseases are out there, which virus families are out there, mutating, developing, evolving, and potentially present a risk to humans is very important work. But it's needle in a haystack work. It's quite difficult to do. Where I'm most concerned is at the animal-human interface itself. Most of the danger is coming from poorly managed biosecurity and monitoring at that interface, and I'm talking about legal and illegal transport of animals across borders, the farming of wild animals, the multi species breeding of animals, especially small mammals. If you look at the emergence of disease over the last number of years, very often it's a small mammal that's involved in the spread of that disease. Can be bats, can be rodents, can be any number of different animals. So I do think there's a tremendous amount of work to do to regulate better the animal-human species barrier, and particularly that barrier relates to wild animals getting into the human food chain, or exposure chain, and particularly where there is farming of those wild animals, because that appears to me to be one of the biggest risks. And we need to do a lot more to support our veterinary colleagues in regulating that side of the barrier. We may complain about our lack of resources on the human side of things, but I can tell you our colleagues on the veterinary side struggle even more deeply, and especially given that agriculture is so economically important in so many countries, that when people try to put in biosecurity measures, it's often seen as an unacceptable cost. It's purely seen as a cost. It's not seen as actually an investment in protecting the industry. It's seen as a cost. And people working on that are not seen positively by industry in many of those situations. So there's a lot to be done to support our colleagues on veterinary epidemiology and veterinary science to manage that animal-human species barrier much more effectively.
Thank you. Another question: may artificial intelligence be useful in identifying new pandemics?
Absolutely. We use it now. We use it now for epidemic intelligence. We use AI for scanning the internet and looking for potential hits, and being able to scan literally millions of pieces of information, to be able to do that, both written, audio, visual information out there on the World Wide Web. We can use it for that side of things. We can certainly use it for developing simulations and looking at simulations. We have a new center we've established in Berlin, which is really looking at pandemic simulation. We can use AI for that as well. And the other part of it is in looking potentially at, when you've got all of these millions of sequences and we've got samples from different species all over the world, well, then being able to look at what viruses have potential to cause epidemics, I could see AI as hugely valuable, and being able to go through such a huge amount of information at any one time. And the databases around genetic sequencing are growing so exponentially that you will need AI to be able to sort that out. And I think the other way is in therapeutics. I think we're seeing AI used more and more to look at small molecules, and being able to look at thousands and thousands of potential small molecules to see whether they would have any potential use in developing antivirals or antibiotics. So I think AI is here very much, and it's here to stay. And I think it can be an extremely useful adjunct to what we're doing. But I don't think AI is going to replace the human thinker in all of this. It's what we do is very complex. We have to join up many different services and different sciences. So I think humans are going to stay very important in this. But AI as a tool in each of those areas and more is a huge potential.
Thank you. And how much do you feel the ability to rapidly sequence the virus impacted on the management of the COVID pandemic?
I think it really helped. I mean, it allowed us to track the virus and not just look at gross numbers, but see how different variants were emerging. It helps us to look at everything from virus evolution to virus recombination. It also allowed, obviously, we wouldn't have the vaccines we have now without the sequencing and being able to develop the mRNA vaccines. Diagnostics have been absolutely based on the ability to test for concerned sequences of the virus. So there isn't an area of this pandemic response that has not been touched by our ability to rapidly sequence the virus and use that sequence for positive effect.
Okay, thank you very much. That brings us to the end of our questions. And so I'd like to thank you, Dr. Ryan, for a fantastic talk and insights into your role and those of the WHO. I think it's given us a lot to think about and leads us very much into the rest of the talks for today. So thank you very much. We will let you go back to your well-earned holiday. Thank you very much.
Thank you very much, Prof. Bye-bye.
So now we have a short break. We are looking for 2 volunteers, one in person, that's you in this room, and another one online to give a quote about what they're enjoying about the event and what International Pathology Day, why it's important to them. Any person can give, you can make yourselves known to the team or online to the international@rcpath.org, and one of the team will be in contact with you to collect your effusive happiness about coming to the meeting today. There are for those of you, not those of you online, I apologize, you'll have to go and make your own cup of tea or coffee or whatever it may be, but for those of you in the room, there are refreshments on the other side of that wall in the park room. Please can you return promptly for 11 o'clock, by which I mean sort of a couple of minutes to 11 o'clock. And there'll be a countdown slide that shows you how long you've got till we restart. So thank you very much and see you again at 11.